All right, good afternoon, everyone. Thank you for joining us for Updates in Pediatrics live stream. So Updates in Pediatrics is a monthly live stream program which takes place on the third Wednesday of each month at noon. And participants will receive a link following the program for an evaluation. You can also use the QR code that will be displayed following the live stream today. So I'd like to introduce our speaker for today. And so Dr. Andrea Krause attended the University of Indiana School of Medicine and completed her pediatric residency at Cincinnati Children's Hospital. She then joined us in hospital medicine at Norton Children's Hospital and the University of Louisville. She's now an associate professor of pediatrics at the University of Louisville and has spent the past 10 years being the leader of our acute medical stabilization program for eating disorders at our hospital. Dr. Krause is also involved at advocacy at the state level with the Kentucky Eating Disorder Council to help expand eating disorder services in our vastly underserved state. So I would like to turn this over to Dr. Krause, who will be speaking on the diagnosis and management of eating disorders. So welcome, Andrea.
There, helps to unmute myself. Hi guys, so thanks for joining me today. And in the interest of time, we'll go ahead and get started. I'm just trying to, okay. Okay, so I have no relevant disclosures to talk about. And here's our objectives. So today, we're going to review the common diagnostic criteria for eating disorders. We're going to discuss very practical and relevant guidelines to assist in the approach of eating disorders. And definitely practical is my theme here. I'm going to provide an overview of the current state of resources that we have in Kentucky. And then there should be a decent amount of time for some questions or discussion towards the end as well. I made sure to include some time for that. So just a little bit about me. After I started my career here at Norton Children's Hospital as a pediatric hospitalist, a few years in, about 12 years ago, is when I started to kind of head up the medical stabilization of eating disorder patients that we would see in the hospital. The then medical director, Dr. Steve Wright, had come to the hospitalist division saying that we needed some assistance for the psych liaison team that we have. Had been seeing some cases come through, but it's a very unique diagnosis and not something that most pediatricians have a ton of experience with, especially not then. And so at the time, I don't like to not know how to approach a patient and take care of a patient. And so I thought it sounded interesting and I decided to kind of take that on. And now 12 years later, I had no idea that this would kind of, explode the way it has, especially in the last 2 years. But just a comment to say that I do not work alone, and the full team of providers that helps to take care of these very intense patients consists of our psych liaison service, our expressive art therapy, our child life department, care management, our nursing staff, dietitians, my hospitalist partners more and more, as well as the families that we take care of. So, and so, as far as like, how do I fit in as a hospital-based pediatrician, it actually ends up being a good fit for these reasons. So, as a hospitalist, and most pediatricians are used to practicing family-centered care involving the family and shared decision-making and open lines of communication. Eating disorder patients are some of the most challenging cases that I have encountered in my 15-year career. And it's kind of striking to me how that stands out in my memory. And then specific to Kentucky, we don't have that local or regional treatment center for eating disorders. So that's been lacking this whole time. And then as far as a hospitalist, we tend to be really talented at managing multidisciplinary care, which is really what a patient with an eating disorder requires. And so just a little bit more about the climate of Kentucky here. at the time, and technically still to this day, we don't have inpatient adolescent coverage, although thankfully we do now have an outpatient adolescent doctor that has joined, Dr. Brittany Badal. We have no eating disorder residential programs in the state of Kentucky. And I don't know that we ever have, and there's none in the works. We have limited outpatient options, although that's gotten better, especially in the last 3 to 4 years. And then, as you all have noticed, and I'm sure that's why there's been such interest in this topic today, there's a growing number of patients, especially in the last 2 years. So I have kind of been the default in a way of kind of taking care of these kids that end up really, really sick. And so, you know, don't ever take for granted the ability to just share a meal, you know, with your loved ones, is another takeaway from this talk. So it's impossible to talk about this without just getting into, you know, the definitions and classifications. So the DSM-5, Diagnostic and Statistical Manual of Mental Disorders, was the 5th edition was published in 2013, which is nearly a decade now. And so that publication provided these kind of 5 diagnostic criteria. So there's anorexia and bulimia, which we all kind of think about. And then the other 3 within this classification would be avoidant restrictive food intake disorder, otherwise known as ARFID. And I'll go into that description in a little bit. And then the otherwise specified feeding or eating disorder, or OSFED, which kind of took over the old diagnostic criteria. They would call it eating disorder not otherwise specified. So now we use OSFED. And then there's binge eating disorder, which is not something that I have experience with. It's a disorder that's very common, but tends to be more of the later adolescent, early adult onset and adult onset. And so that is definitely not my area of expertise, but it is within the classification, so be aware of that. So within anorexia itself, we have the 2 subtypes. There's the straight, you know, classic restrictive subtype, and then there's the binge eating and purging subtype, which we'll see as well. Where there is kind of purging, whether that's by vomiting or excessive exercise, the misuse of laxatives, diuretics, etc. And then, okay, that one didn't. Okay, so this is kind of my schematic with anorexia and nervosa. So we have the classic restriction of energy intake, intense fear of gaining weight, and then that undue influence of your body weight on self-evaluation. And then with anorexia specifically, there's going to be a significantly low body weight. And that's not specifically defined within the DSM. It used to be less than 85% ideal body weight, but they don't go into those definitions as much anymore. And so be aware of this kind of label, I suppose, for anorexia, the egosymptotic feature of the illness. And so that's a very technical psychiatric term, but basically it's important to understand that an egosymptotic illness is an illness that a patient doesn't have very good insight into the illness. They don't want to give up their behaviors. They see their behaviors as completely acceptable, and that's the way they want to live their life, basically, when they're within this severity of illness. And then also in the 2013 iteration of the DSM, amenorrhea was removed from the diagnostic consideration, because otherwise we were just completely ignoring the fact that men can also have this illness. And so the mortality rate is 5 to 6%, which is pretty high. It's the second highest of all psychiatric diagnoses. And actually, interestingly, suicide is the #1 cause of death. About 50% of those deaths are, a little bit over 50% are from suicide. And these illnesses have the highest treatment costs compared to any other psychiatric disorder as well, even more so than schizophrenia. And then the peak age of onset, that's pediatrics, that's age 13 to 18. And so that's why this is so important, that pediatricians and people that do take care of teens, adolescents, and older children are aware of this illness. So then bulimia, the kind of classic features would be the recurrent episodes of binge eating, the sense of lack of control over eating, eating in a discrete amount of time, and then some kind of compensatory purging behaviors, whatever that may be. And so the time frame of this is usually eating a discrete amount of food within a 2-hour period. And that large amount of food is not really defined other than it's more than what most people would eat. And then there's this sense of lack of control over their eating during that episode, and then that compensatory behavior afterwards, whether that's purging, fasting, or compulsive exercise. The binge eating, usually by definition, it would be occurring over a 3-month time span and longer. And then on the flip side, to anorexia, bulimia tends to be an ego dystonic illness. And what that means is there is this intense fear or intense guilt and shame associated with the behaviors that go along with this illness. And then bulimia officially tends to occur in older teens to college age kids. But that being said, someone could start out as anorexia, kind of in adolescence, and that can transform over time. So just be aware of that. So the comparison, the side-by-side comparison of the two, that we talked about the onset, a little bit earlier onset for anorexia. There's this personality features that are somewhat kind of classic with anorexia. It's kind of more this type A, obsessional, perfectionistic personality. And then kind of with bulimia, there can be more impulsive behaviors, that go along with the illness too. And then another thing to be aware of is that while anorexia is always underweight, bulimia, you don't have to be underweight. You can have be overweight, have normal weight, or be underweight. And then we talked a little bit about the denial or egosyntonic features and the ego dystonic features of bulimia. So the OSPED classifications, the one main one I want you to take away from is the atypical anorexia nervosa. So this doesn't fulfill all criteria for anorexia, but it can be significantly harming to the patient. So basically it's the same features as anorexia, the self-esteem and the body image issues and the restricted intake. However, the weight is normal. And so usually what that looks like is a patient that is either normal weight or obese even, that starts in with these behaviors and restrictions, and then they come to you needing medical stabilization potentially, and they can actually get as medically unstable as anorexia with regards to bradycardia, and pretty much all areas. And so I think that it's nice that we have a definition for this now. I think some figures have shown that about 20% of all patients admitted for anorexia actually have atypical anorexia nervosa, so they have a normal BMI. And then avoidant restrictive food intake disorder is very fascinating. That again is a new category. There's this lack of interest in food and eating that can look like a food aversion based on sensory characteristics. It can be extreme picky eating. It can be a choking phobia, which is a little bit more sudden onset. We've had kids that choked on a piece of popcorn and then just pretty much stopped eating all solid foods. I've had a patient before who had dental work done, and the pain associated with that procedure made them stop eating, and they were fearful of eating. And then we do see this kind of category of ARFIDs where it's more of a functional abdominal pain that leads to restrictive food intake and weight loss. And again, that would be a diagnosis of exclusion. The eating disturbance itself is not classified as anorexia or bulimia. Again, there's no body image distortions within an ARFID as well. So that's important to remember. And then we don't also have like an underlying medical or psychiatric condition that would lead to this kind of restriction. And ARFIDs by definition usually tend to be younger kids. We've seen a child as young as 4 present with an ARFID. So that's something else to be aware of. So some key points, and I already kind of mentioned this, that eating disorders are the second deadliest DSM diagnosis. It's actually from suicide. And then we do know that there are better outcomes associated with an earlier identification of the illness. And so basically early intervention is key. And so that's another focus and something to remember, another takeaway. So the longer illness duration can be a predictor of poorer outcomes. And in the study that I have kind of referenced in the references, it is basically a duration of 3 years or longer that can lead to a poor outcome. in theory, and by this publication, it's easier to identify an eating disorder illness in adolescents than adults. And that's basically because they're generally in the care of their parents, and the parents will notice these things. Whereas an adult, is not necessarily going to get captured. And yes, eating disorders can happen adult onset, it's just not the majority. So, all right. And so again, our longer illness duration can correlate to these neurobiological changes that have been noted, but they've done functional MRI studies too to kind of support this. But it kind of goes back to this theory of neuroplasticity, in that if the brain is kind of chronically starved in this state during an eating disorder, it basically changes our nervous system and our neurons. And it's basically can be very hard to overcome that if the patient gets stuck in that state of starvation for, years on end. Another takeaway is that the suicide completion rate for patients with eating disorders is 18 times that of their peers, which is really just astonishing to think about. So there are 30 million Americans that will experience an eating disorder during their lifetime. This here is information from the Eating Disorder Alliance, which is actually, I've got a link to their website here. So basically, the other thing that we know, besides 30 million in America, specific to Kentucky, thanks to the work of Dr. Levinson's group, we would estimate that about 900,000 people in Kentucky are suffering from an eating disorder. And based on some surveys that they had done at the high school level, there are 1 in 10 Kentucky high school students that have more than 3 disordered eating type behaviors. So there's a lot out there. Are we really seeing more cases, or does it just feel like it because everything's awful because of COVID? Well, actually, yes, we are seeing more eating disorder cases, in fact. And so there's been several published studies that talk about the COVID-19 effects, and that was really immediate. As soon as COVID started with the lockdowns, that current patients at the time in like March 2020 were having kind of worsening resurgence of symptoms. But then studies that they're really too numerous to talk about, further studies have looked at and shown increasing cases in general. And so that's, I think, because eating disorders thrive in isolation, we do know that. And then there's larger, kind of more unfettered access to social media, and that's certainly not helping things either. So, and it doesn't seem like things are slowing down. So this is information from Norton Children's eating disorder cases. Now, just understand that this is only through August, so we still have some catch up to do. These numbers were acquired by our IS team. But basically, if you can see the year on end, 2017 to 2021, in August of 21, we had just as many patients as we had the year prior. We have definitely topped out and exceeded by far that number for the year. If you look at the age distribution, the pink, mostly pink bars in the bottom, you'll see that the age distribution is pretty classic. Not sure how we can explain the 1-year-old on the left, but it's a pretty classic age distribution. And one would assume that those kind of younger ages that you see cropping up on the left are probably ARFID diagnoses as well. And then this graph here, these pie charts here will show there's some diversity that we're seeing with race. And then by gender, the breakdown is pretty similar, where it's about 85% female and a 15-16% male, which is what we would expect. And then something that maybe you all don't think about much, but I do think about a lot in my job, is the case payer mix. In that we are seeing, close to 40% of these patients are on public assistance on Medicaid. And so I think that we need to start removing some of these preconceived notions we have about eating disorder patients being kind of the upper class, Caucasian females. It could be anyone. And so, yeah, again, they do not discriminate. Eating disorders do not discriminate for age, gender, race, class, sexual orientation, or body shape and size. And so as far as physical exam clues are concerned, I kind of am like presenting this information because a lot of times in this way, because a lot of times patients with an eating disorder will come to you and it's not like that's their chief complaint. They're not saying, hey, I have an eating disorder, I need help. Sometimes you have to figure this out. And so, and I know there's probably a mix of people that are on the line today with different backgrounds of whether you're a primary care doctor, or nurse practitioner, or maybe a behavioral health person. But in general, some physical exam clues to malnutrition specifically. On the left-hand side, a flattened affect, kind of depressed state, pale skin, dry skin, cachexia and facial wasting. A decreased muscle mass is pretty key. I think that's a very important finding on physical exam. The thinning hair and that fine lanugo that you'll see like at the nape of the neck or the backs of the arms. Sometimes a heart murmur can develop, which is essentially can be like a mitral valve regurgitation if there's enough heart changes, if it's been a chronic enough longstanding anorexia case. Acrocyanosis can occur just due to kind of overall decreased circulation in that kind of starvation state. Palpable stool mass, because all of these patients generally, if they're having food restrictions and energy intake is too low, their GI motility is terrible and will have constipation. And then delayed pubertal development, so not quite getting their periods on time if female, because those sex hormones need energy to develop. And then specific to bulimia on the right-hand side is dental enamel erosions, this Russell sign, which I'll show a picture of, parotid gland enlargement and bruising. And actually bruising could be from compulsive exercise sometimes, but bruising can also occur just in a malnourished state from kind of poor skin integrity. And so here's some pictures to go along with it, just a few highlights. And so on the right three, the muscle wasting that you'll see is key. That lanugo that's on the side of her face there. The acrocyanosis, the blue fingertips, cold blue fingers are that I always see that in the patients that I'm admitting to the hospital, that is always there. And then the severe constipation is generally, if the patient is malnourished and not constipated, then obviously this is a whole separate area of concern. But usually they should really be constipated. And then on the left-hand side, the atrophy of the cortex. So this is, I think I like to point this out because I think it's something that you can talk to your patients about. It's like your brain is shrinking in a state of malnutrition. And so, and you can't really, scare someone straight per se, but I think overall it's a talking point that we can have when trying to help our patients. And so this imaging literally shows that the cortex has shrunk down. And so some physical changes with bulimia specific, these enamel erosions, which is something that dentists everywhere know about. But even us as a primary care provider, you can take a quick peek into the mouth and get a very good impression of what's going on. And again, with bulimia, the guilt associated shame, the patient may not be as forthcoming about what behaviors are happening. The parotid gland swelling is very classic. And I actually see the parotid gland swelling more than I see the Russell sign, which is that sign of kind of trying to induce purging. So something to keep in mind. So the other thing to remember, and this has helped me a ton as a pediatrician who didn't necessarily have experience with taking care of eating disorder patients. Over the years, I've kind of been self-taught, but read a lot. I've read a lot. And this book, the Locke and Lagrange book, Help Your Teenager Beat an Eating Disorder, was very helpful for me. And so just think of the disorder as separate from the patient. And so basically over time, with weight loss and restrictions, the disorder takes over. And so that is a very important and crucial way because it helps us help our patients basically, because a lot of times the talk can be a lot of blame can be assigned, and we never want to do that when we're taking care of these kids. And so that concept of, I guess, externalization, I'm not a psychologist, but I've definitely had enough experience at this point, that point of externalizing what the illness is and trying to tease out that from the patient is super important. And what another key part of therapy is naming the disorder. So that way the patient can actually say, well, this is, I'm trying to think of some of the names over the years, but ED comes up a lot for eating disorder. But they choose a name, and it can be like a monster sometimes, which is actually helpful in therapy. And these are just some quotes that some of our patients have said over the years. He wraps around me like a python, keeping me from eating too much. And this patient actually devised a piece of art out of clay that looked like that. And then he, meaning the eating disorder, is sly and cunning like a fox. And then other patients that just want help. I want help. I want to feel normal again. And that's a patient that had good insight. So some typical behaviors of worsening illness that parents will describe about their children. It can start out subtly, prescribing to a healthier diet. Lent is coming up, watch out. We just got past the New Year's with resolutions. So it can start out innocent enough. And then there's this fixation sometimes on calories. Sometimes weighing themselves frequently can be a feature. Taking smaller portions, so that how the patient is with eating can be really revealing. And so sometimes parents don't notice these behaviors, but they can start taking smaller and smaller portions, being really slow to eat, playing with the food or hiding food. And something that we see commonly is food play, where the child is like spreading the food out on their plate. So in the end, you can't actually tell how much food they've really eaten. So anyways, it's important to know these things, because if we're not looking for them, we're never going to know how to help the child. And then again, just a reminder that these are very clandestine behaviors. And so we really have to be wise to these things to know what to look for. The parents also describe the child kind of starting to avoid social eating, whether it's, family gatherings, going out to eat at restaurants. Those things can cause a lot of stress in a kid that's really struggling with an eating disorder. And then wearing extra layers of clothing, whether that's to cover up weight loss, or is that just because they're so cold because of the weight loss. And then another thing that we hear a lot is the family will describe just a totally different personality in their child. It's not the same child we once had. And then social media habits, I just throw that in there because I try to include that in my intake assessment of like, okay, so how many hours a day do you spend? What are you looking at? Because that alone can be very revealing. And so some of the psychological changes, the distorted body image can be very delusional, almost near psychosis at times, depending on how underweight the child is. Again, there's always this link with the negative body image and a really terrible self-esteem. I talk about this, my body is different mentality. So you can kind of think, well, how could someone do this to themselves? How can they not see that this is harming them, that they could die? And that goes back to the egosyntonic illness. They don't see that. And in fact, a lot of times if you ask someone who's struggling with an eating disorder, they kind of have this belief that, well, I think my body is different. This isn't going to happen to me. I'm not going to die from this. So, and then another reminder, this is really interesting. I always like to talk about this. So there's this publication in 1950 by Dr. Ansel Keys at the University of Minnesota. It was called the Minnesota Starvation Study. The study itself was actually conducted in the 1940s. Dr. Keys did the study in preparation to help with the end of World War II and the concentration camp survivors, Holocaust survivors, as well as prisoners of war, POW survivors. So they actually recruited conscientious objectors from the war. These happened to be, there was a large Quaker community in Minnesota at the time. And so these were volunteer adult males that were starved over a period of several months. And so what Dr. Keys found was that, well, first of all, what he did was he actually calorically restricted them, not a ton. He ended up restricting them to, I think it was like an 1,800 calorie diet. But in addition to that, he also made them walk a lot, like miles and miles each day. And then what he found was during that kind of malnutrition process, these men who were Quakers were actually like just not acting themselves at all. They would show more aggression. They would be depressed, have terrible moods, things like that. And then with this work, he also actually published information about refeeding syndrome as well, and kind of things to look for. So I just think this is a nice thing to remember because of how our patients' personalities are affected in a state of starvation. And so the other thing that the Minnesota study showed was that these starving men actually became quite obsessed with food. They were writing about it, talking about it. And so it's just really interesting. And we do see some patients that become very obsessed with food, where they're, watching the Food Network obsessively, looking at social media posts about food, things like that. So, and then, with the internet, unfortunately, there's some negative things that have come about. In the last 10 years, it was these pro-ana blogs or pro-anorexia blogs. And so this is kind of transformed in the era of social media, but the pro-ana blogs or pro-MIA for bulimia blogs will basically show these images and memes and GIFs, things like that, that are just kind of, I feel like it's almost like the internal voice of the eating disorder in a way. It's kind of manifested in this form, but they will post about diet ideas and little, sayings to kind of help overcome the urge to eat, things like that. And so we do know that if someone exposes themselves to this for too long, they do become brainwashed by it. And so modern day social media influences, currently TikTok and Instagram, to me seem to be like the biggest kind of offenders. And I don't know if you can read this, but this TikTok video titled, it says, "What I Eat in a Day," as a signed model working in Tokyo, Japan. And you could imagine the content there is probably pretty, not helpful for someone. And then this Instagram content on the right, I had one dark chocolate chip. And even the hands themselves kind of look like acrocyanotic as well. But just know that patients, if they have unfettered access to this, that's another area where we can kind of help out and try to mitigate these kinds of exposures. And so our differential diagnosis of weight loss is something to consider, especially if you're in the outpatient setting. You always want to make sure you're not missing the obvious. And again, like I said, these illnesses are not always just like telling you exactly what's going on. You're not always going to get that. So we'll run through our differential: inflammatory bowel disease, GI disorders like celiac or achalasia. And that's why an ESR can be super helpful when you're doing a workup for someone that's had weight loss. Hyperthyroidism, Addison's disease. I've had a child referred in and they ended up having Addison's disease. Hypopituitarism, type 1 diabetes. I've not seen that yet. Usually people will catch that. Malignancies. I have yet to this day to catch someone that actually has a malignancy from weight loss, if that's what they're referred in for. But that's definitely on the differential. HIV infection and tuberculosis are two considerations. And then within the psychiatric realm, depression, substance or opiate use, and the use of diet pills is something to get information on. Early pregnancy technically is something to consider. And then I have had a few cases that were kind of borderline. They had weight loss, and it definitely coincided with the start of a stimulant for ADHD. So, and I say that because ADHD stimulant use is very prevalent. And so it's just something to consider. And so there's a lot of food pictures here because this is what we end up talking about a lot. And my friend has recently taken up cheese boards as her pastime. And so I always enjoy those images. But okay, so in our office visit in the outpatient setting, just some things, kind of general recommendations. As someone who sees these kids after the fact, I do wish that we were a little bit more neutral when it comes to weight. In the office setting, I do worry sometimes that obviously you have to have really very real conversations with parents if their child is kind of tending to have a too generous BMI, but we have to be very sensitive about that. And I don't know that I know what the perfect balance is, but weight neutrality is key. If you're seeing a patient that has a known eating disorder, you want to try to blind the weight until you can kind of assess where they are in their illness. Because definitely early on, before they've really gotten any significant therapy for their eating disorder, the weight itself can be very triggering. And so blind it at all possible, hide the scale, get a scale in your office that has that capability, like a digital scale where you don't see the readout. Have them remove their shoes so you can really trend the weights. And then we in the hospital will weigh the child in their gown and nothing else. So if you have that ability in your office, and if you do have a lot of eating disorder patients in your office, you might want to figure out a way that you can do that. And then take note of any changes, but you, again, keep the weight discussion neutral. And so some hang on one second. Okay, there it is. I was a little slow. Some vital sign red flags that we sometimes maybe don't notice, or maybe just kind of say, oh no, I think that's nothing. Hypothermia is quite common in my patient population, and a lot of times it doesn't quite get the recognition it deserves. Orthostasis, and we'll go into the definitions of orthostasis in a little bit, but that blood pressure and heart rate change with lying, sitting, and standing. I don't know how often we will do that in the outpatient setting, but if it's somebody that you're worried about having an eating disorder, you need to do those orthostatic vital signs. And then our resting heart rate is key. And we'll get into the actual numbers, but that resting bradycardia, and technically that's about 50 and lower, is when, okay, that's a red flag. This might not be normal. So, and it's all about context as well. I want you to remember this calculation for anyone that's kind of trying to run numbers and try to figure out where the child is in relation to where they need to be. What's good for the adolescent population, there's a million different calculations out there to get ideal body weight, but for our adolescent population, this actually is my favorite. It's the height in meters squared multiplied by the BMI for their gender and age at the 50th percentile for their gender and age. And so that gives you your ideal body weight. And then you'll see in a few slides how a lot of our discussions around eating disorder treatment really goes back to percentage of ideal body weight. So just save this calculation for later. And then other tools in the outpatient setting that we would want to consider, lots of screening forms that can be very involved, but here are some basic ones. Oh, there we go. The HEADS assessment, which I think a lot of people in the outpatient setting probably are familiar with this one. I like the SCOFF questionnaire because it's quick. 1 point for every yes, and a score of 2 or more indicates likely anorexia or bulimia. Do you make yourself sick? Do you feel you have lost control over how much you eat? Have you lost more than 1 stone, which is British, 14 pounds in a 3-month period? Do you believe yourself to be fat when others say you are thin? That's very important. And would you say that food dominates your life? Okay, I did not warn you ahead of time, but I've got a few QR codes coming up. So I'm going to pause for a second to give you guys a chance to get your cameras out on your phone, point your camera at your QR code, and that'll show you this link. This eating attitudes test is very detailed. And so if you've got the time dedicated to this, this is a super helpful survey basically to give your patient to get a little bit more into the nitty-gritty about the features of their illness that you suspect they have. And denial obviously can always be a challenge. This is the actual form itself in case you weren't able to follow the QR code. But there's some really nice trigger questions there. How they eat their food. Are you aware of the calorie content? Do you like to feel hungry? Things like that, I think as a pediatrician, I had no comfort level with asking those questions. And so I like this form because it has those kind of prompts. So what's your treatment even look like? And so the basic crux is that for eating disorder treatment, you want evidence-based care. Family-based therapy is the key for adolescents especially. And that treatment team should be multidisciplinary with a therapist, a dietitian, an MD. And within that multidisciplinary team, communication is key. And so there has to be an open line of communication due to the nature of the illness. And then this is a link to the National Eating Disorder Association site. It's their levels of care guideline that I love this form. It can be very difficult as you're assessing someone to know if there's a significant enough problem, what to do next. And so this is a publication, the American Psychiatric Association. If you follow this link, it kind of has text, but I'll go through some slides here, but you can save this link for later because I think it can be very helpful in evaluating your patients. And so this is the APA guideline for medical stability, which is referenced in the NEDA levels of care guideline. And in this red box, I've kind of outlined for children and adolescents, what they have described as what's considered level 5 treatment, which is inpatient hospitalization for children and adolescents. Heart rate of 40 is what they say. The orthostatic blood pressure changes, and which would be a more than 20 heart rate increase or the 10 millimeters of mercury decrease with standing. And then blood pressure, total blood pressure of 80/50 or less than that, it would be considered medically unstable. And we see that a lot, hypotension as a cause. Hypokalemia, hypophosphatemia, or hypomagnesemia, because these patients can be total body depleted. It is helpful to get a set of electrolytes in order to see how depleted they are. A lot of times this can be normal. The kids that I most often see them being low in are kids that are purging. So within the levels of care guideline, our level 1 is outpatient, where you're, and remember that not all therapists will see eating disorders. And that's like once a week visits. Level 2 is intensive outpatient program, which is usually several days a week. And it's kind of like a school day where they're doing treatment from like 8 to 3. Then level 3 is a partial hospitalization program, or PHP. We don't have any PHPs in the state at the current time. And that is the majority of your day. You're eating all meals within the program up until, after dinner, basically, and then going and either going home, or if you're a Kentuckian, staying at like a long stay hotel, and then going back the next day. Level 4 is residential treatment. Again, none in the state, unfortunately. And that's obviously they're staying overnight, and it's just eating disorder patients in that facility. And the level 5 is what I do, acute medical stabilization. And then other factors besides medical stability within the APA guidelines as far as where this patient might belong for treatment would be suicidality. That's complex. If a lot of these kids do have passive suicidality, but if it's more active suicidality, then a lot of these eating disorder facilities will not take the child. There's a little bit of a delay here. Oh, there we go. Our percentage of ideal body weight. So the key number to remember is 80% ideal body weight and under would be considered more severe. So it's a little hard to make that work for anything outpatient, intensive outpatient, or PHP sometimes even. And these centers, the closest PHPs in Cincinnati, and they have very specific guidelines, and they may not accept a child if they're too underweight for their program. Motivation and insight is key. Co-occurring psych conditions, about 80% of kids that have an eating disorder probably have either anxiety or maybe some kind of mood disorder. The structure needed to eat is a factor if it requires a lot of structure versus they actually don't need much structure at all. The ability to control compulsive exercise alone, I have sent kids to residential facilities just for that. Purging behavior sometimes can be very difficult to manage. And then environmental stressors, geographic locations, also considerations. Then there's the Society of Adolescent Health and Medicine. This is a much more recent publication in 2015. I like the way they outline it a little bit better just because it's a lot more detailed. And so, the hospitalization, what I like is that there's some kind of caveats where, if they have acute food refusal, they could be admitted to the hospital. If they have failure of outpatient treatment, they could be admitted to the hospital. So those are nice little caveats that kind of help us, with that hospital stay and getting that hospital stay underway. A lot of these things are similar. The specifics with the heart rate are a little bit different. And this is what I use. So the severe bradycardia would be when awake, less than 50, when asleep, less than 45. And then this is a nice little lab coat card from the Alliance for Eating Disorder Awareness. If you follow this link and save it, and I've got it on the next page as well. I like these cards because, again, if you're not that familiar with how to take care of these kids, it has nice prompts for you. And it might be something you could print off and just save for later. And so this is the actual form itself. It's got prompts for review of symptoms. It's got prompts for physical findings to look for. It's got your actual diagnostic codes, which is helpful. And I do like their screening questions, which is a little bit similar to SCOFF questionnaires as well. Another prompt it talks about is fluid intake. And I didn't really mention that, but there are some kids that actually restrict fluid too, in addition to calories in. So these are our lab studies that we would get for a CBC. We would look for, it's freezing, there it goes. Okay, sorry, it's freezing up a little bit. Anemia and leukopenia. For an ESR, we're going to rule out other etiologies if it's elevated, if the SED rate is elevated. An RFP tends to be normal at the time of admission, but again, if it's abnormal, we would anticipate either maybe water restrictions or more purging behaviors. Magnesium can be low, but it's going to drop with refeeding, as will phosphorus. And then the TSH to rule out hyperthyroidism as a cause, but in eating disorder patients that are malnourished, you can see a sick euthyroid picture with like a generous TSH. With AST and ALT, those can be elevated in a state of malnutrition just because the liver cells, it's like apoptosis of the liver cells themselves. So liver cell turnover, kind of destruction due to starvation. And then with an EKG, you would expect sinus bradycardia. If there's anything else other than sinus bradycardia, that's a reason definitely for telemetry monitoring. But also the most common things we see would be QT prolongation, but that's usually because of like electrolyte abnormalities. It's not, or sometimes kids just have it underlying, but if the QT is prolonged, it's probably because their electrolytes are abnormal. Okay. I'm slowing down a little bit because the slides are not turning over as fast right now for some reason. There we go. Insights for the pediatrician. Again, triggering words, weight and calories. I talk about energy, and don't share the weight with the patient until they're in a better place in recovery, just to kind of avoid triggers. And then it is okay if you're a medical provider, it is quite all right to set the stage when you first meet them about how dangerous this illness is. You heard the facts already. You heard about the mortality rate being, the second highest of all psychiatric conditions. You are allowed to say that death as an outcome is a possibility, and we really need to be aggressive about this. And with activity limits, sometimes you have to be very strict and kind of the bad cop to conserve energy. So if this kid is malnourished and trying to run track, it's time to stop. And then additional insights, there's a lot of weight restoration, calories that are required for weight restoration, we call it. At minimum, that's 3 meals and 3 snacks per day. And as the child switches over from a catabolic state to an anabolic state, we see that rev up of the basal metabolic rate. And so that's why we need so many calories. Again, energy conservation is key. Don't let them walk the dog if they're not in a state where that can happen. And then another highlight is that a lower body weight is associated with much stronger eating disordered thoughts. So until we get some weight restoration, it makes the therapy, the psychotherapy, hard. And then our goal in general is about 1 to 2 pounds of weight gain per week, depending on the person. And then ultimately let food be thy medicine, as Hippocrates said. This is a little bit about family-based treatment that we know from the Maudsley approach from years ago. The parents are in control for phase 1. They transition the control to the adolescent phase 2. And then phase 3 is like normal adolescent behavior and development. So they have to kind of graduate to those things. And again, we talk about reducing blame. That's another part of it. Roles of medications for anorexia, not really any medicines other than if it's super severe, like hospitalized or at a residential facility. Sometimes they'll use atypical antipsychotics to help in severe cases. With bulimia, fluoxetine has been shown to be useful for binge purge cycles. However, Wellbutrin is contraindicated due to risk of seizures. And then this is what recovery looks like. Weight restoration for me being number one, but then kind of like a normalized eating patterns as well. And then once in recovery and your weight was restored, everything's reversible, except the main thing is osteopenia. So remember, the DEXA scans are very important. And then as we talked, I've already kind of hit on this already, that there are deficits in Kentucky. So I'll go ahead and just know that if the patient is in Medicaid, that's going to be a challenge. If they're less than 12, that can be a challenge. Our intensive outpatient options in Kentucky here, Aspire Wellness, and then the Louisville Center for Eating Disorders. There's the side-by-side comparison for that you can kind of look at later if there's a particular patient you have in mind. Norton Children's Medical Group has Dr. Badal at Adolescent Medicine. And so she can see patients as well, though it's not like a multidisciplinary clinic. She's very experienced though. And that's how you can make a referral. And then Norton Children's Medical Group currently working on a multidisciplinary eating disorder clinic. So that more to come on that. Elsewhere in Kentucky, UK, Adolescent Medicine has an eating disorder clinic. Dr. Mandakini Sadir runs that. If you are tuning in from not the Louisville area, but closer to Lexington. And then I just wanted to plug the Kentucky Eating Disorder Council that we started last year in January of 2021. We're working on state level advocacy, mental health parity is a target. Our outreach and education, as well as research with that. And it's currently led by Dr. Stacy Roussel. I'm not sure if she's out there today or not. And then as a medical provider, if you could, and haven't done this survey already, the council has produced this survey for medical providers, kind of to get a sense for comfort level that providers may have with eating disorders. And I think in the chat or the Q&A, there will be a link for if you're a behavioral health provider, that's a separate link to follow. So that'll be copied and pasted in the comments. And then resources, we'll skip past that. These are two recommended books. Both of these books have helped me, although both books are actually recommended for parents of kids that have eating disorders. So I highly recommend them. And then many thanks to my psych liaison partners, Elizabeth Sanders Martin, her expressive therapy, Amy Wakeman, who works so hard trying to take care of these kids in the hospital. Sherry Steffen and Annette Carlisle Spots have been a huge advocate at Norton. And then Dr. Supple, Pruitt, Levinson, and then Mary Beth Tivaba are all eating disorder providers in the city that have been helpful to me throughout my career, honestly. So, and there's some references. And then questions and discussion, we'll go from there. Okay, so there is a question here about how the question says, could you discuss how often patients should be followed with labs, weight checks, and so forth after medical stabilization? And so I would say the answer to that kind of depends on what that looks like. If they're going home from the hospital, that one would assume that then they're a little bit more stable weight-wise. So the lab checks are probably not as important at that point, immediately going home from the hospital. Weight checks at minimum weekly. But a lot of, if they're seeing an ED therapist, the therapist will actually be weighing them as well. So, so to kind of answer that question.
Andrea, can you discuss your statewide council and what you guys want to achieve?
Yeah, so we are currently, what I've been the most involved with is trying to hit the insurance providers in the state because reimbursement is so poor and actually even compared to like Indiana and Ohio, it's much worse for eating disorder care. And so what we found with the council is that probably the reason, it's like the chicken and the egg, but probably the reason we don't have many resources in Kentucky is because it's not financially sound to create a PHP in the state. And so there's been some workarounds. So for example, Aspire Wellness, Dr. Supple's group is actually working on maybe doing a PHP like in Southern Indiana across the river because it'll be more financially feasible for them to do it there than here in Kentucky. So we met in December with the Board of Insurance to try to at least tell them, hey, this is our plea. but getting traction with them is a challenge. So we definitely need advocacy, with the state legislators and stuff. And Julie Rocky Adams has been a very good advocate for us and helped us form the council to begin with.
And then what do providers do when we strike out with trying to, find psychologists or the, outpatient treatment, or even not fully hospitalization?
I know. And, it happens a lot more than I'd like to admit to, especially in the last year and a half, it's been happening. And it can be a lot of different reasons. It can be because there's just no access to care for the child due to their insurance. Or it could be the family's in a state of denial too. That's unfortunately happened on a few occasions. And so, for example, there's one patient that I've been I will get probably about weekly communications from the provider that's taking care of this child. And then Dr. Badal has been helpful. So this child who really needed residential, they've been seeing weekly their primary care physician, and then I think every other week with Dr. Badal to try to patch them through. But this is a child that definitely needs residential, and there's definitely kind of like scholarship programs out there. I think it's called, I'm blanking on the name for it, but there's a scholarship program that can be applied to maybe get some funding for someone to go to residential, but I've not seen that actually pan out for anyone yet, unfortunately, despite referring several kids that way.
And then with our severe patients that we hospitalize,
Yes.
how often do we have to find an inpatient treatment center for them?
Right. It's like, I would say maybe, so right now it's been about 20%. Oh, Project Heal, Amy's just put in the comments, that's the scholarship program. Maybe 20% of the kids that we take care of end up going to residential. Maybe I would like to send more, I don't know. But again, we come into difficulties both with insurance and sometimes the families as well. If you look at a family and say, well, your 13-year-old probably really needs to go to a residential treatment facility, but that's states away, it's really hard to kind of sell that, unfortunately.
Okay, and there's another question about parents who do not have the financial ability to afford the treatment of these kids. And then what options do they have?
Yeah, so that's where, so far what we've patched through is just, the primary care doctor has to really kind of own it, unfortunately. And I think that's where Norton comes in helpful, in that we are trying to develop a clinic, a multidisciplinary clinic. And my hope is that will fill in some huge gaps in care that we have. There's other centers like in San Diego, they don't even really send kids to residential treatment. They basically medically stabilize them, weight restore them enough, and then get them to their IOP or PHP program that's associated with UCSD. And that's probably a better model of care, especially for our adolescent population.
All right, very good.
Mm-hmm.
Very relevant, especially with the data you show about the increase.